Welcome, everyone, to the Cultivating Compassion Education series, sponsored by Compassionate Care ALS. We're honored today to present Dr. John Hansen-Flaschen, the Paul F. Harron Jr. family, Emeritus Professor of Medicine at the University of Pennsylvania. He served from 1990 through 2014 as the Chief of the Pulmonary Allergy and Critical Care Division at Penn. As Division Chief, Dr. Hansen-Flaschen founded the multidisciplinary Paul Harron Lung Center at Penn and served as the medical director until 2015. Dr. Hansen-Flaschen is a career medical educator focusing on medical ethics and humanism. His scholarly interests have focused on reducing the burden of advanced lung disease and critical medical illnesses for patients and family members. His many honors include the Praxis Award in Professional Ethics from Villanova University, the Leonard P. Lang Award of the American Lung Association, and the Career Achievement Award from the American Thoracic Society. Welcome, Dr. Hansen-Flaschen. Before we begin the presentation, I'll turn it over to our founder, Ron Hoffman. Welcome, Ron.
Thank you, James. Welcome, everybody. Excuse my voice. I've got a cold thing going on. I'll be brief. I met John several years back, and first time I spoke with him, I knew I was really impressed with the work that he was doing. We found much commonality in his work and the work that we do here at CCALS. He very much, his knowledge is second to none. And for me, he's a man who truly comes from his heart, a man who truly cares about the people he tends to and cares for. So I'm really grateful that John was able to find time to be with us today. And John, welcome to you, my friend.
Oh, thank you very much, Ron. And hello to everybody this Sunday afternoon. I've titled this talk, Breathing is Everything When You Can't. If you have ALS, but it's not very far along, you might not get that yet. If you're a family member of somebody who's been through advanced ALS, you know what I'm talking about. Breathing is everything if you can't. Nothing else matters. I've learned a whole lot about breathing in ALS, not 20 or 30 years ago, but just in the last several years. And I'd like to share a little bit of what I know today with all of you.
And John, excuse me, I'd invite everyone, if you have questions along the way, please put them in chat. And then along the way, at the end, James will read those questions, as many as we can.
In 2015, I was preparing to retire when I saw my first ever patient with ALS, Jay Fishman, with his wife, Randy. I told them I'd not taken care of an ALS patient before, but I had some general advice on how to live with a chronic progressive disease. Talked about leaning in, anticipating, learning what's coming, anticipating, preparing in advance of need to avoid crises and setbacks and drama and go smoothly as possible through the disease. And he really adopted that, taught it himself nationwide as his disease progressed. Randy and Jay offered the University of Pennsylvania more than $3 million on a request that I build a program for home-assisted ventilation at Penn. We'd be the first in the Mid-Atlantic region of the country to serve people with ALS and other neuromuscular diseases along the lines that we had talked about in our many sessions together. And I took on that challenge. Today, the Fishman program for home-assisted ventilation at Penn is nearing 6 years old. We have a staff of 9, more than 350 active patients, an active research program going on, a lot of teaching locally and nationally and internationally, and can claim to be a leader in this field. Had a very steep learning curve and are continuing to learn. But I must say, this is an extremely gratifying form of my long career It's not a nice disease, ALS, but the impact that we can have on it keeps me going and keeps me young. First insight I want to remind you of is that there's not one but two vital organs of respiration. The lungs serve gas exchange, put air, oxygen in the blood, and excrete the waste product carbon dioxide. The second vital organ, the respiratory pump, complex matrix of muscles and bones, and a central driver in the brainstem, move air in and out of the lungs. The respiratory pump is to respiration what the heart is to circulation. Both are equally essential to survival. Without either one of them, animals, people die within 5-10 minutes. ALS has no known effect on the lungs, but it causes progressive weakness and ultimately failure of the respiratory pump in just about everybody with the disease. The implications start subtly and become more extreme as respiratory failure ensues in ALS, starting with breathlessness, with exercise, or talking or eating, with an impairment of sleep, can be subtle and not easily understood at first, with a weak cough that impairs protection of the lungs. And then as the poison carbon dioxide builds up in the blood, subtle and more oppressive brain fog and confusion and lethargy. Most people with ALS die of respiratory failure. For that reason, I consider this as much a respiratory disease as it is a neurological disease. It's one of the common important causes of respiratory failure, which is core, front and center in our specialty of pulmonary and critical care medicine. There's some good news. As early as 2006, we've known that there's effective treatment for progressive respiratory muscle weakness in ALS. It's a very well-known study, 2006, where patients were randomized to non-invasive ventilation or standard care. And you'll see on the left-hand side, the very short survival for people who got standard of care, and considerably longer survival in that study for people who got non-invasive ventilation and had mildly impaired bulbar muscle dysfunction. At that time, there was very little impact on people with severe bulbar dysfunction. But in addition to prolonging life, non-invasive ventilation was shown at that early time to substantially improve quality of life. These are for all comers. The red is without non-invasive ventilation. The blue is with non-invasive ventilation. Mildly impaired bulbar dysfunction, not so much for severe bulbar dysfunction. Now, that was not so many years ago, but already there's some very good news. The state of the art of non-invasive ventilation has advanced dramatically since 2006. That study will never be repeated because no one wants to be in the control arm. But we have good reason to believe that the impact on survival and quality of life is much better today under optimal care than it was in 2006. The equipment now is sleek and lightweight and highly effective. Here's a Louisa ventilator on a bedside table with a single tube going to a mask to a patient in the bed. We can do a lot of things today with assisted ventilation, non-invasive ventilation, not possible even in 2006. The man in the blue shirt to the left is Jay Fishman. He was the chairman and CEO of Travelers Group, Dow Jones Industrial Company, and he was the host of a 2016 professional golf tournament in Hartford, Connecticut. Here you see him wearing his nasal mask, hosed down the back of his head, to a small portable battery-powered ventilator on the back of his chair, talking comfortably to one of the golf pros. This is cut from a short video, and it was pretty clear to see that these are professional athletes, but Jay Fishman was the strongest, most confident person in the video at that time. A real achievement of the technology that we have available today. When respiratory failure occurs early in the course of the disease, before progression of limb weakness, people can walk around with their ventilator. Here's one of our ALS patients. He's in his left hand, he's carrying a battery-powered ventilator. See the mask that he prefers. He's walking down the hallway of our clinic. There he is, flying in a plane. Battery-powered machine between his legs. And riding on one of the thrill rides in Disney World. You see him in the middle there, having a great time with his family. And traipsing across an inlet on a paddleboard with his ventilator balanced on top. That's a $20,000 ventilator, but he wanted to show off and show that he could do this safely, and he did it just fine. Today, non-invasive ventilation enables quality of life unbelievable just a few years ago. And today, under optimal care, most people can go the entire duration of their disease with mask ventilation, ensuring normal ventilation, reasonably comfortable breathing, tolerably comfortable sleep. Here's the bad news. Only a small fraction of people with ALS in the United States currently have access to optimal care. The technology and the science has advanced so much faster than the practice in the United States that only a small number of people have access to the kind of care that would enable the adventuring that we just saw there. And this is shown in current data. This is a study published in 2019, an analysis of the US National PROACT clinical trial participant database. This was several thousand people participating in clinical trials of drugs for ALS. So these are sophisticated people under sophisticated care. Non-invasive ventilation was used at the time of only 52% of office visits for patients who had at that time a forced vital capacity less than 50% predicted. Now, that's severe muscle weakness that qualifies by Medicare criteria for use of a ventilator. So these people qualifying with severe respiratory muscle weakness, only half of them were using NIV at the time of their office visits. And of those who initiated NIV, 15% subsequently abandoned the treatment. So the impact is greatly limited compared to the potential for this treatment. And I think there are multiple reasons for this. And one is that we're kind of still stuck behind in a model of care for ALS that needs to be updated. This is from the ALS Association website. Maybe you're familiar with it, that they've established multidisciplinary care centers headed by a neurologist, a physician, and staffed by non-physician clinical specialists and personnel to address various aspects of the disease, including a respiratory therapist. There's no pulmonologist in this map. It's a neurologist and non-physician specialists, including a respiratory therapist who's largely responsible at many centers. And here's how conventional respiratory care still unfolds in many places of the country that adhere to that model. And neurologist submits an order for a bi-level device or a ventilator to a durable medical equipment company nearby. That company dispatches a respiratory therapist who sets up a device in the person's home in an hour and a half session, adjusted to make it comfortable for the person. And once that individual is using it, goes about their way to see other patients. If the person isn't able to adapt to the machine, they live the natural history without ventilatory support, or even if they do get started with it, when the machine no longer provides adequate ventilatory support for sleeping and for breathing, for coughing, very often in current practice, that person is advised to consider tracheostomy or hospice on the theory that the machine is non-invasive ventilation is failed. Or alternately, all too commonly, the person who didn't start an IV or abandon it, or is using it suboptimally, gets a respiratory infection or some other acute stress, and is admitted emergently for acute respiratory failure to an intensive care unit. And tracheostomy is considered under great stress, mostly by the family members at that time. This approach leads to death much sooner for many patients than is necessary. One of the problems is a respiratory therapist, this is really a misnomer. Occupational physical therapists and speech pathologists have terminal degrees, equivalent of doctorates. They're very highly trained in the physiology and the medicine of their conditions, as well as the technology. Respiratory therapists prepare for practice with 2 years of technical training beyond high school. Sometimes that's embedded in a 4-year bachelor's degree. Respiratory therapists are really the equivalent of technicians. They're trained about the same as radiology technicians or EMG technicians, not in the same category as the other therapists that ALS patients might read. They don't have prescribing authority. They can't bill for their services. Well, they can go and follow protocols to set up a machine. But and some of them are very highly skilled and very experienced, but in general don't have the deep and broad background and expertise to solve problems that often occur as somebody tries to get on top of the machines that are used to support ventilation. And so it's customary to get early on into talk of tracheostomy or into hospice care without even knowing whether the machine has been optimized. There's reasons for that. The knowledge of how to do non-invasive ventilation has been accumulating rapidly. These are publications in English language on non-invasive ventilation in the scientific literature. They'd only started taking track of non-invasive ventilation that was so new in 2010. And you can see a dramatic increase in the number of publications published per year, now several thousand. And the neurologists can't be expected to keep on track of all that. And respiratory therapists or technicians not reading that literature either. At the same time, there's been an explosion of sophistication and devices that can be used to support people with chronic respiratory failure. Many of these devices require specialized knowledge and settings and come in different sizes and configurations that are quite advanced and need a whole lot of specialized knowledge. Well, I don't think we're ever going to get to optimal respiratory care for ALS in the current multidisciplinary care model. And instead, I propose a new care model where neurologists and respiratory medicine specialists who have a special interest in chronic respiratory failure collaborate in co-principal care of people from diagnosis to death. Pulmonologists, not as one spoke in the wheel, but a pulmonologist heading a care team side by side with a neurology care team headed by a neurologist. In this model, the neurologists are essential to make the diagnosis very challenging with ALS. They're doing this cause and cure research, which is so essential to ensuring a better future, and prescribing and modifying disease-modifying medications that are starting to have effect on the disease. They focus on mobility and communication assistive technologies through the non-physician collaborators on their team. The neurologists are very well suited to address the mental health care stresses of patients and caregivers as well. On the other side, the other team, headed by a respiratory medicine physician, pulmonary and critical care, or maybe a sleep doctor, focuses broadly on respiratory care. And because feeding is so dangerous for people with ALS, and because critical care doctors have a lot of experience with tube feeding, it makes sense to put enteral feeding, tube feeding, under the umbrella of the respiratory physicians. And we're internists, we can take a look at the other diseases and conditions a person has and make sure that the right specialists are involved and include into ALS, that all those other conditions can be optimized while somebody is fighting their ALS. So this model has two people involved and would lead to very different kind of care for respiratory failure that I've outlined here. Now, this is physician-directed respiratory care for people with ALS in the model that I just described. And I'm going to walk you through this step by step. First recommendation is an early referral from the neurology-led team to the respiratory physician-led team. By early, I mean as soon as practical and as soon as the person has recovered from the shock of the diagnosis and is ready to learn more about what their disease will bring forward to them. In a first referral, before any respiratory symptoms, a pulmonologist can look to those other medical diseases, make sure they're covered, and talk a little bit about what somebody might expect and a timetable for addressing respiratory dysfunction as it arises to the future. Also recommend early initiation of non-invasive ventilation and another form of respiratory support, cough assistance. Increasing data now shows that this type of care should be started when the forced vital capacity, a measure of respiratory muscle strength, drops below 80% predicted, and with early symptoms of respiratory muscle dysfunction. Well, Medicare only covers for less than 50% predicted, but it's complicated and there are ways around that. So less than 80% predicted is abnormal. Abnormal weak respiratory muscles by this test is already about half gone respiratory muscles. And the symptoms that we look for are intermittent, uncomfortable breathing with activities of various kinds, walking around or activities at rest, like moving your bowels perhaps. And then for appearance of disrupted sleep, very, very often in ALS, impairments of sleep are caused by worsening of respiratory muscle dysfunction at sleep. And then there's a symptom that's a telltale. People who are uncomfortable breathing when they lie flat already have fairly advanced respiratory muscle dysfunction, even if they're still able to maintain a vital capacity near normal. So those are situations where with some skill and some finesse, it is possible to acquire a high-level device or a ventilator and get somebody started early. One of the reasons to start early is it could take quite a while to get everything set up just right for somebody to be comfortable with the machine. So this leans in, runs ahead of the desperate need for ventilation and avoids a setback crisis. We also recommend early initiation of a cough assist machine. And there's a simple measurement that we can make in the office, how fast a person exhales when they cough, that tells us that coughing muscles are so weak that a person can't protect themselves from ordinary infections or even the mucus that accumulates without infection in the lungs and starts to compromise lung function. So early initiation of assisted breathing is the second step. Then it takes some real expertise and finesse to get the machine right, to order the right devices, and to set them up properly. Masks for non-invasive ventilation come in 4 general configurations shown here across the board. And there are a total of 200 different devices that can be used. It's like the number of men's shoes for work. It's a huge number of devices that are available, some highly specialized, and it takes a lot of knowledge and experience to get just the right mask for somebody that they can breathe comfortably and effectively. And then there are modifications to masks that are sometimes needed, tapes and adjustments. And here are chin straps that may be needed to hold the mouth closed when somebody uses a nasal mask. So a lot of expertise required here. And this falls beyond the purview of respiratory therapists, who generally take only three or so masks into a home, 2 or 3 kinds of masks of different sizes, and then shrug their shoulders if those masks don't work. It's also important to choose the right device. These are bi-level devices. I don't use the term BiPAP because that's a proprietary term to Philips. It's like using Kleenex instead of tissue. On the left is a Respironics device. On the right, a ResMed device. These smaller devices are suitable for some patients early on in ALS with slowly progressive disease. They're convenient because the heated humidifier is built right into the machine. They sit on a desktop. They don't have a battery. You can't go anywhere with them except in a suitcase. The higher level machines we call ventilators. There are a number of them. They range in 4.5 pounds to 11 pounds. And these are full capability life support devices. They don't have a built-in humidifier, but they do have built-in batteries and a complete selection of alarms. And with these devices, it's possible to precisely control and customize every step in breathing in and out. It seems like a simple thing. You're doing it right now, but there are a lot of different components to it. And fitting a ventilator to somebody that they can live with it for the rest of their lives means getting each of those individual components just right. These machines are optimally designed to do that. There's 2 common kinds of cough assist devices that I tell you are equally effective to keeping people with ALS out of trouble, keeping them from developing atelectasis and pneumonia that brings people down in time. So a lot of effort is required to do that, and it cannot be done by just submitting an order to a respiratory therapist. Instead, we recommend a physician-directed in-office optimization of home care, guided by quantitative monitoring. And now it's possible to have the same measurements of device function and physiological response that we count on taking care of people with respiratory failure in an ICU. And this is all respiratory physician level care. Here is a ResMed Astral ventilator, and you see in front, off to the side here, is a modem. The ventilator Bluetooths to this device, which transmits by telephone 1 to 3 times a day, a complete report of how the machine is functioning and how the patient is responding. The data coming from this is extremely sophisticated and complex, and we can access it, username, password, into a central server and gain a whole lot of information about how the machine is working at home during sleep, which is often dramatically different than what it is when people are sitting up during the daytime. using this access to this ventilator data, we find many serious problems in people who come to us for a second opinion, tracheostomy or hospice. We look at this data and we say that question is premature because your machine is no longer set appropriately for you. It's not affected. It's not functioning effectively, and we can dig in and fix that. The other device we use is a transcutaneous CO2 monitor, a new machine, quite expensive, not available in many places, but we have 2 of them in our office. Now, this gives us the ultimate information we need. The respiratory system puts oxygen in the blood and gets rid of carbon dioxide. And here it is. There's a sensor attached to an ear with a wire, and now we see heart rate, oxygen percent saturation like you get with a pulse oximeter, but this is very much more accurate. And there's a missing number up there, the carbon dioxide level in the blood. If that number goes above the normal range, 35 to 45, we know the respiratory pump is failing and very vulnerable. So we can run that device in the office as we're adjusting and titrating the machine to get the settings just right. Here's our office respiratory therapist, essential member of our team. And this is the same guy who was traipsing around Disney World in a previous photograph. There's the transcutaneous CO2 monitor. I'm sitting at my desk, and if I turn around, then I'm looking at the data from the last several days generated by him at home with his home ventilator. And we're working back and forth to make adjustments and modifications to the settings of the machine that it syncs just right and accomplishes the intended goal in a comfortable way. This makes all the difference in the world in our ability to get people successfully on board with their machines. The next thing as part of this optimal care is to start tube feeding early. Conventional teaching is that you should start tube feeding optionally if you want to, when you've lost 10 or 15 pounds, when your nutrition is failing. The other reason to start tube feeding is because of weakness of swallowing muscles with a growing tendency to aspirate fluid and food, not into the stomach, but into the lungs. That bacteria-laden fluid going into the lungs stirs up inflammation and causes small pneumonias. It blocks off areas of the lungs, causing atelectasis, and is the process that brings people down when they're using home ventilation. So we monitor very closely people's symptoms, asking, do you have congestion in your chest? Do you feel like you need to cough? And we examine people with the stethoscope and hear them breathing and encourage the initiation of tube feeding when it's clear that aspiration has begun. We can do specialized tests to check for it if we need to. It's important to do this before the first pneumonia, not after one, and when you're in an ICU already. ALS progresses. The settings that work on day one don't work anymore by some time later, whether it's 3 weeks later or 3 months later or 6 months later. The person has to be seen on a regular basis, the data reevaluated, and adjustments made continually so that the machine continues to normalize respiratory function and sleep and overcome people's breathlessness. That's something that is not built into durable medical equipment, home respiratory care. They set up the machines and their responsibility is most of the time pretty much done. Now, if you have a really good home ventilator and you're using it, you know how to use it in the day as well as the night, and you have a really good cough assist machine and you know how to use it and it's working effectively, well, you can endure many respiratory infections at home without having to go into a hospital and into an ICU and risk being intubated and being threatened with a tracheostomy. This is life support. When life support is used by knowledgeable people in the home, it can support people's lives through the ordinary stresses of mild to moderate respiratory infection. So we help people plan and gain confidence in advance on the expectation that's going to happen. Sometimes they call us, we provide antibiotics through the feeding tube or intravenously if necessary, pick up the use of the machine, use the cough assist machine very, very commonly, and get people through an otherwise stressful situation without having to leave their home. Pulmonary and critical care physicians who work in ICUs have lots of knowledge of end-of-life care. Most people die in ICUs. And most people in ICUs die after a decision is made to withdraw life support under deep sedation. This should be an option for people with ALS. Our notion is we want to help you live as fully and productively and as independently as possible for as long as you want to live. But when the weakness and the problems of this disease become overwhelming for you and your family, and you say enough is enough, we want you to be able to bow out gracefully and calmly and peacefully without experiencing pain or suffocation under medications that help you fall asleep. This can be done legally and safely, routinely in ICUs. Some hospices do it. Too few places make this available in people's homes, but it's just a matter of getting the right people together and knowing how to do this, that people can live with confidence as long as they want to, without having to fear that they'll be kept alive beyond their time because of no good way out. Still today, too many people with advanced disease, tracheostomy for the most part, now weak from top to bottom, family stressed out, are just lying there waiting for a respiratory infection that's bad enough to knock them down. They're just waiting for that to happen. And a respiratory infection that's unplanned and not treated properly is a terrifying experience of suffocation and terror for all people around. That's not the only option that people should have for the end of this disease. We think that the approach we use routinely in intensive care units ought to be more widely available for people with ailments. Well, I've described advanced respiratory care. And this slide shows some of the people in the United States who are capable to varying degrees of providing the care that I just described. These are all pulmonary and critical care sleep physicians and people trained in both, all academic physicians. And these are some large cities in the country, but there are many other cities and smaller towns that don't have any of this yet. I think that many of you might live in the Boston area, so I'm highlighting here Catherine Dudley at MGH. She's an experienced pulmonary critical care and sleep physician who has just joined the ALS program at Massachusetts General. She's just beginning and doesn't have the kind of program set up at MGH that we have now at Penn, but is beginning to gather experience, and she might be the go-to person for the kind of care that I described in this talk today. Meanwhile, I'll ask this question, what can you do? What can you do to advance respiratory care to the current state of the art across a larger fraction of the United States? Well, I hope that you can begin to advocate for the development of specialists in chronic respiratory failure at your hospital and nationwide. If you're being referred by a neurologist straight to a respiratory therapist at home, or to a pulmonologist who doesn't seem to have any special particular interest in this, make a stink, bring it up. This is now an essential part of the care of ALS and other neuromuscular diseases. And there's advocacy that's needed nationwide, and that's beginning to happen. It's possible some of you participated in this. NIH released a draft strategic plan for ALS research to apply to federal funding and foundation funding, private philanthropy that had almost no mention of research on respiratory disease, almost none at all. If you buy into the idea that breathing is everything and that people need a pulmonologist, a respiratory medicine specialist as much as a neurologist, particularly in the second half of the disease, then you might have, or you might have wanted to sign this petition. And if you see over here, victory, in 4 days that this was circulated, 695 friends of ALS signed the petition. 28 physicians signed an additional letter complaining about the lack of this in the NIH plan. And now the NIH has said that they will modify the plan to include prioritization of research on respiratory care for ALS. So people who have a disease and their family members and their advocates can have a very powerful voice locally and nationally. There's something else I just want to mention briefly. I gave you a list of people who might be capable of doing advanced respiratory care for ALS, but I don't really know that. Those are some people who signed our letter and have been involved nationally. And I pulled their names off the signatories of the letter we sent to NIH. And I know some of them, and some of them are as skilled as we are, and some of them are developing into this field. But right now, patients across the country cannot find out who is a specialist in chronic respiratory failure, who's willing and interested and has advanced training to take care of people with ALS. So I'm proposing that the right small group of people would come together and take it upon themselves to build a national registry of respiratory disease specialists, a list, and a state-by-state map of the US. You click on the state and you see who's the specialist in that state. This group would have a small advisory board of pulmonary and critical care sleep physicians who know who's who. And there'd be a simple application form of practices who want to be listed, reviewed by that small group of physicians. And then this group of volunteers would maintain over time this registry, directory of people who can provide advanced respiratory care. This would be similar to the list of neurology-led teams that the ALS Association maintains currently. They have no such list for pulmonologists. And if you bought into what I have to say today, I think that people should need to be able to have access to that through ALS Association or through compassionate care or some other place that's easily found that people can find their way to the kind of care I've talked about today. Well, in a few minutes, I hope I've convinced you or reminded you that breathing is everything when you can. Mobility, communications, nutrition, those are all very, very important. Mental health, very, very important, but not if you can't breathe. Not if you're sitting there thinking about every breath you take, sitting in fear that the bottom is about to fall out and you're heading towards suffocation. Breathing is everything. The woman in this photograph heading toward home on a tricycle is using the ventilator with its battery attached to the back of her tricycle. It gets all around as a very active and engaged anesthesiologist, retired anesthesiologist from the ALS. And if she were listening to this talk, I am confident that she would encourage you to agree with her that breathing is everything, and that we need to step up our game in respiratory care of ALS across the entire United States. All right, thank you very much. I'll close off my sharing if I can. Can I do that? end share, pause share. Let's see if that works.
Yeah. Thank you, John. So what I want to do, James, can you unmute, please?
Yeah.
So really like to there's some really good questions in here, John. I'd like for James to read them. There's probably about 16 or 17 questions, maybe a few less. And John, if you could address them succinctly to think of time, because there's some people have some thoughts here.
All right.
You good with that, James?
Yeah, that sounds great. There's a bunch, John, so I'll start here. Mashi is asking, what has been your experience with non-invasive ventilation with patients who have ALS and FTD? I would think that unless there is severe apathy, most FTD patients would unfortunately not be able to tolerate these devices. What do you say?
Well, it's a very sophisticated, appropriate first question. This non-invasive ventilation requires a lot of engagement, focus, concentration, engagement, and willingness by the patient. And that horrible, horrible manifestation of ALS very often stands in the way of the kind of participation a patient needs. So there isn't anything about the dementia that worsens breathing, but itself, but it's a major obstacle to the back and forth communication, collaboration, give and take that's necessary to get everything just right. So, in honesty, we have very limited experience with people who have moderate to advanced dementia. We work extra hard for those who have mild disease, working very closely with their family. We've had some successes, but that's an area where, well, maybe some of those people don't want to go the direction of assisted ventilation and more into sedating medications as they become necessary. And there are a few reasons still to do tracheostomy, a very few, and this might be one of them.
And if I could add one thing, FTD can be incredibly gentle to very extreme. So a lot of it's dependent upon where that particular person is.
James, can you keep going through it? It's helpful for me if you pinch the questions to me.
Yeah, absolutely. Okay, thank you both for those responses. Susan is asking, are there comfortable masks that allow you to talk while you're trying to wear them?
Yeah, by all means, yes, and a little bit no. So I think you saw Jay Fishman talking to a photograph of Jay Fishman talking to the golf pros wearing a nasal mask. A nose that fits over the nose or underneath the nose and presses up against it gives you full access to your mouth. And I thought I saw one of you in the screen is wearing it.
Yes, he was there. You saw that.
Yeah,
Yep.
so here, and that's perfectly good. The problem is that with bulbar muscle weakness, some people with ALS lose the ability to close off the back of their mouth so that when they open their mouths, while they're using positive pressure ventilation, there we go. Matt Hogan is demonstrating. When they open their mouth, some people with ALS, all the air leaks out their mouth. So they're trying to talk in an open airflow that's coming from their nose down through the mouth and is uncomfortable. Some people learn how to do it, but others don't. The patient I showed you in Florida had a full face mask because he was one of those people who leaked uncomfortably through his mouth. So some people with ALS can wear a nasal mask like Matt is doing there now and talk during the day, and some people can't. There is a device under development. It's an amplifier that attaches to a full face mask that makes somebody much more understandable if they try and talk under a full face mask.
And one thing I might add is you could also eat and drink with it on.
Yes.
Thank you, Matt, for that demonstration. We have a question here now from Alyssa. She's wondering, is there any data on using NIV on people with ALS if FVC is above 50%?
Yes, European data and some US data showing improved outcomes, improved survival when non-invasive ventilation is started with a forced vital capacity below 80%, not 50%, below 80% with the addition of any symptoms. That's the current practice in Europe now. A group of pulmonologists got together and made a recommendation to NIH, to Medicare, that the criteria be changed to sync with the current knowledge. Hasn't been done yet, but there are kind of fancy ways we can get around it. So there is sufficient data now to justify starting NIV, FVC below 80% with even early mild symptoms.
Thank you, Dr. Hansen-Flaschen. So Thomas is asking, he's saying that he tested well. He has bulbar onset, but the respiratory therapist would not order NIV. What does he do in that case?
Yeah. Well, you got to go somewhere else. I showed you that data from 2006 with no improvement in survival and quality of life for people with that severe bulbar disease. That is so out of date. That is so yesterday. You know, we have plenty of people with bulbar disease. And a large fraction of them, starting early on, with some finesse and back and forth and patience and perseverance, we are able to get full nighttime ventilation and daytime ventilation despite bulbar onset disease. So that is way, way out of date. That's an example of practitioners today not keeping up with the knowledge and science and the technology that we have today. And it just upsets me so terribly that so many people get better answers than that. Go somewhere else.
Sounds good. Thank you. Kim is saying, in my opinion, caregivers and people with ALS should be trained in setting adjustments on NIV equipment. You can unlock the devices and change settings. Give them access to manuals and sufficient training so they can respond to their person with ALS who is progressing and or goes through an emergency. Also, let's just say, do you agree with that, Dr. Hansen-Flaschen?
To a modified degree, yes.
Okay, so then the further question is, FVC is an outdated measure of breathing capacity. One PALS has 70 on FVC, but inspiratory and expiratory strength is above 100%, with MVV at 120%. Do you believe that that's accurate?
Yes, I have a patient that's maybe that same patient or someone very similar to that. FVC is the most commonly used measure of respiratory muscle strength. It has its merits, but it's not the whole story. There are many other considerations that we look at to decide how weak someone's muscles are. When the forced vital capacity is below 50%, most of the muscle is gone. People die at autopsy. There's a little bit of muscle left. The rest is scar tissue. So vital capacity is one tool. There are other useful tools that are used. That carbon dioxide monitor sometimes show people are retaining carbon dioxide when their vital capacity isn't very bad. So we consider the severity of respiratory dysfunction from a variety of perspectives. I just want to come back quickly to should you mess with your own machine. It is a very complicated machine. It's very, very complicated. So to some extent in our practice, particularly when people are very far along and we're managing them by telemedicine, we give them instructions. We let them unlock and we give them instructions and tell them where they might want to make fine tuning and adjustments so that they can speed up the process of finding comfort. So that might be the inspiratory pressure, for example. We'll show them how to do that. And in a telemedicine visit, they'll make the adjustment while we watch and listen, or we'll say, play between these two numbers and get back to us in 3 or 4 days what you think is best. So to the extent that you're being guided and advised by a counselor who's a real expert in the machine, I think that people can make some of those adjustments. But a full ventilator, there are hundreds of different options in there. And you can get hopelessly lost and unable to get back to where you are if you're not careful.
Yeah, good point. All right, we have Giuseppe with a question about what can I do as a patient to delay the need for NIV? Do you have any suggestions besides early referral to a pulmonologist?
I wish exercise helped. I wish nutrition, good eating helped. Today, it's just the beginning of some medicines that delay the course of ALS a little bit. And so best bet for delay is to be right on top of the medications that are currently available to modify the course of ALS. And we're hoping for much more sooner. Beyond that, I'm interested in starting the non-invasive ventilation earlier rather than later, to get introduced to it, to get settled into it, to find the right mask in the right settings before you really need it. So for the most part, my answer to that is no. And a recommendation, you don't try to fend off this machine. It's your friend. It can become your best friend. So don't be so afraid of it and fight it off.
Thank you. Ron, do you have anything to add there?
No, honestly, using things before you need it. Just like John mentioned, it's like, it's great exercise. The more you can get used to something, then when you really, really need it, it's going to work a whole lot easier for you.
Thanks, Ron.
Yeah.
Kim has a question here. There was a study that breathing exercises either with equipment or stacked breathing can help. The equipment in the study was less than $20, available on Amazon and called a breath trainer. So kind of in the same vein of how do you delay the need for assistance?
Yeah. Well, one of my colleagues at Penn, Jason Agrivo, has an NIH grant to study that question. So he is studying the benefit of stack breathing. It comes by other names. What that means is using a machine or a handheld device, $20 handheld device or a machine, to take sigh breaths, much bigger breaths than you can do spontaneously. All of us sigh to open up and expand our lungs and reduce atelectasis. And there's reasons to think that regularly doing a sigh maneuver or a breath stacking maneuver might help the lungs be more functional, might make it easier for the ventilator. I don't think it'll have an important impact on when people start assisted ventilation, but it might be of help. And we're doing a study now to test it.
Sounds good. Melanie is wondering, I saw a pulmonologist who told me that my peak flow was 250, therefore insurance would not cover the cough assist that I feel I need. My PFT was 66% to 60%. Does anyone know what the Medicare, Medicaid actual criteria are?
Yeah. There isn't a strong criteria for cough assist, but the threshold is 260. And you know what? If I'm looking at you and you have a weak cough, the strongest cough you have is a kind of pathetic cough, and you have some mucus in your chest and you've got bronchitis or something, well, you don't have to cough as hard as you can. I'm sorry, but a little bit less hard coughing, you make the criteria. This should be a clinical judgment, not a number judgment. And there are ways to get around that vital capacity. many of you may know that the vital capacity is much lower lying flat than it is sitting. And then Medicare doesn't know whether the test was done sitting or lying, so do it lying down and you'll qualify. The rules are outdated. We don't really advocate breaking rules, but in support of our patients, we will be a little bit creative. When somebody has weak respiratory muscles and already is beginning to have symptoms caused by that. So there are ways to get around it. That pulmonologist is included. He doesn't know.
Thank you. Melanie seems like she has an additional question to ask. Can you unmute there, Melanie? She's trying. There we go. Still can't hear you though.
Is this better?
Yes.
Yes.
Okay, thank you. So when I had my pulmonary function test, it was 66% and 60%. Is that helpful for getting the cough assist and the whatever you said, bilateral?
60. The two numbers, the vital capacity was 66% and the FEV1 was 50. So that's just above.
Lying down was 60.
Yeah, so that's just above the
Okay, so I'll do it
however,
again.
if you have symptoms,
Try so hard.
if you have, I didn't say that. If you have symptoms, if you're having trouble with your breathing, if your sleep is deteriorating, if you're uncomfortable lying flat, the test can be repeated with you lying flat, and I promise you'll make the criteria.
Sounds good. Thank you.
And Melanie, you might want to share with your neurologist that you're incredibly afraid. You have breathing episodes. All right,
Oh, sometimes I'm up all night trying to
Come on, why should you suffer? Wait for some stupid outdated number.
just advocate more for yourself.
Thank you.
Can I take a
Will do.
second? Christine, can you turn on your Christine Termini, can you turn on your camera? There you go. I just want to introduce Christine Termini. This is Sunday afternoon. She's a mother of young kids, and she's a respiratory therapist, and she joined in today. And I couldn't do what I do without her. You saw us in the room as a two-person team doing the titration of the ventilator. She's hands-on, and I'm in the back causing trouble and monitoring things. So I don't want to put her on the spot here, but I just wanted to introduce Christine. I'm not against respiratory therapists. I just think they need a well-trained respiratory care specialist to work with hand in hand. The same way a nephrologist, a kidney failure specialist would work hand in hand with a dialysis technician.
Beautiful.
Good. Well, thank you for being here, Christine. Nice to meet you. The next question for you, doctor, is what is the test for whether aspiration is occurring?
Okay. If you have sense of mucus in your airways that you didn't have before, you're aspirating. If you can feel some fluid going down the wrong way that makes you cough when you eat or drink, you're aspirating. Don't have to go any further than that. Then there are two tests that are used. One is called a modified barium swallow. It's a radiology technique. The radiologists do fluoroscopy. They continuously watch your swallowing while you swallow this opaque material and various consistencies. And they watch the coordination of the muscles of the mouth and the tongue and the throat while you swallow. And they can see in coordinations, and they can see if some of it goes beyond the vocal cords and into the airways. The other one is called FEES, F-E-E-S, functional evaluation, functional endoscopic evaluation of swallowing, FEES. That we do with the help of a speech pathologist in our office. You're sitting there in a chair, and a small viewing scope goes through the nose into the back of the throat. And then that's projected onto a television monitor, and you swallow, and we can watch exactly what happens to colored liquids and soft solids. And we can see if it's all going properly or into you. So you don't even have to go to radiology. If there's a speech pathologist that can come to the office and do this technique with you, it takes about 15 minutes. Those are the two tests that we can use if we're not sure whether somebody's at risk for aspirating.
Thank you. Even though we started late, we've gone a little bit past the hour, and there's 20, 30 more questions, Doctor. So
I'm okay if you are. So I'm happy going as long as we've got an audience and as long as you're willing, Ron.
Ron, I can't hear you, buddy.
Some of those are statements and people going back and forth. So just find the questions. Okay.
All
Please.
right. Well, we'll keep going through. Thank you for hanging in there with us, John. Appreciate it. So the next one from Mashi is: are there any sites or providers in New York City that are doing similar quality work to the Fishman program?
Yes. The New York City setting, the New York City practice is in Philadelphia. So it's a long story.
The internet password's not working.
But in the entire greater New York City metropolitan area, I'm not aware of a single pulmonary critical care sleep physician who's fully trained and engaged in our national community that's doing it. So I'm trying very hard. I'll go here. So I've identified a champion that is fully equivalent to me in the Midwest who wants to and is willing to move to New York City for family reasons and set up a program in the city. And it's not happening because these practices are so labor intensive, insurance reimbursement doesn't pay for it. So to make it possible for him to set up New York City's first program would take a couple $1 million or more, the same kind of support that we needed to get up and running at the University of Pennsylvania in Philadelphia. So if any of you is quite wealthy and you live in New York City, and you're appalled that 20 million people who live within an hour drive of the city don't have this at all, let me know, and I'll help steer your buddy into a way that would make a lasting and very substantial difference in the care of ALS in New York City. Boston, the first person who's stepping forward to doing this in the Harvard system in Boston at all is just getting there now. I can go on and on.
Yep. Thank you, sir. Susan is wondering, in the very early stages of any breathing issue for someone with ALS, is it helpful to use the NIV for just a couple hours a day, possibly during a nap or for a few hours at night?
Yes, like to start early and get you up and running and acclimated to the machine. So some people, day one, they wear it all night long and they're grateful for it. And other people have to inch and ease their way in. So it won't change the natural history of the disease if you're using it a little bit sometimes early on. But it'll help you gain experience with it, and the experience you get, and us seeing how the machine operates online with that database that I showed you would help get the settings right, the mask adjustment right, the right mask for you, and getting you adjusted to it. So as you need it more and more, it's a smooth, easy transition onto all night long and then into daytime ventilation. So as a part of recommending you get started with this early, I'm happy when people will inch their way in a couple hours at a time.
This is Susanna Makovsky. Might add a comment to that too. So I just joined CCALS, and reflecting on what you had just said, and one of the things that Ron often says is this is a illness that is associated with a lot of fatigue, and fatigue from respiratory effort is real, And that translates into using up energy in a lot of different areas. So being able to wake up rested, not having to work hard at night or after a nap, the amount of energy that you might have during the day for other activities could really be affected. So in addition to the learning process and that steep learning curve, the opportunity to actually get a deeper rest and not have to work and breathing while you're lying flat or lying down, sleeping, I think could make a difference for the energy and quality of life during the rest of the day.
Oh, perfectly and well said. People don't automatically think about weak breathing muscles when they're having trouble sleeping and when they're fatigued during the day. They don't know that might be the solution to the problem, at least for a while.
Thank you, Susanna, and thank you, John. The next question is from Giuseppe. He's wondering, do we have any advocates in Medicare or other carriers to help get these NIV devices supplied?
Yeah. Well, elaborate a little bit. A group of leaders in pulmonary critical care sleep medicine, leaders in managing chronic respiratory failure, put together an elaborate set of recommendations. They're published in the journal Chest. You can find them online. Summarizing the advances in the science since 2006 and a consensus for when assisted ventilation should be initiated in the care of ALS. And it was received a year ago, and there's been no response to it so far. So still no change in the Medicare policies, and we really don't know why. There's a very glaring discrepancy between their policies and where the state of the art is now. And I can't let private insurers off the hook. There's some really nasty, cynical, abusive actions by health insurers, parallel to, and sometimes even worse than Medicare. You know, if you have ALS, you can get Medicare, and pretty much I recommend you do so, because even though Medicare is outdated in their policies for respiration, we can get there with Medicare much better than we can with some of the private insurers.
Okay. Melanie is wondering, and I'm not sure if this is going to be in your wheelhouse or not, John, but she's saying, can a primary in New York State help with a peaceful demise?
Yeah. Yes or no? I can't answer briefly. So you may know about assisted suicide, medically assisted suicide, and New York State is not one of the states that enables that. New Jersey is. But and that may be of interest to some people with ALS, particularly those with frontotemporal dementia. But if you become fully dependent on assisted ventilation, whether it's mass ventilation or tracheostomy, it's life support. You need it to survive. In every state of the country, you can forgo that treatment, take it off, or have it taken off from you at your own request legally. Yep. And then it's just a matter of being sure that you don't suffocate when that happens. So not in New York State for a prescription of a failed dose of medications, but yes, in New York State for what I call palliative withdrawal of life support under titrated sedation, not a deliberate overdose, but just enough that you fall asleep and you don't suffocate when you come off the machine. Do it most of the time. For most patients who die in an ICU, that's how they die.
Yeah, that's a longer conversation, having to know this person's circumstance and their situation. You know, are they BiPAP dependent, if you will? Are they invasively ventilated? You know, everyone has choices. whether you're have a tracheotomy and invasively ventilated or not. Many people choose to stop nutrition because their quality of life is no longer what they wanted. And it's
I just wanted to plan. I'm not there yet. I just wanted to envision the future.
sure. So Melanie, what we can do, if you want to be in touch with me along the way, we can always explore and I can share with you what's possible. Okay.
Thanks.
And Melanie, as a new member of the team and a palliative care physician of CCALS who lives and works in New York State, I'm happy to go over some of the nuances
Yeah.
here as well.
We'll make those connections, Melanie. James, go ahead.
So next we've got Susanna. Did you want this ask this question? Do you still want this question asked about the University of Rochester?
I can do that offline. I'll touch base offline. That's okay.
Okay. Eric's asking if he can get a copy of the presentation. Absolutely. We'll email a link to all those who signed up. Melanie, yes, we'll send a link. You kind of already addressed this, doctor, but this person, Mark, is wondering if current ALS medications have been shown to delay respiratory problems.
I believe the main outcome that's been studied recently is survival. By implication, or I'm hedging a little bit. There is a delay. There's a documented delay in the rate of worsening of forced vital capacity. So to a limited degree, yes. The medications that are starting to become available are beginning to have a favorable impact on the natural history of the disease. Some of them are pretty burdensome to take and offer very limited, but just in the last year, some medicines are pretty exciting becoming available. By all means, explore that.
Good, thank you. Susanna, there's another question in here from you to Dr. Hansen-Flaschen. Do you want to handle that offline as well, or do you want?
I'll handle that offline. Thanks.
Yeah, about hospice offline. Thank you.
Okay. Okay. Suzanne says, I always think of George Floyd. He certainly was having some respiratory problems. Bruce is wondering.
What could be more frightening than suffocation? What? Tell me what.
Yeah.
Slow suffocation. Tell me what's worse, more frightening than.
Yeah. Bruce is wondering, can you comment on early initiation of NIV during sleep for individuals with normal waking FEV but mild abnormalities on polysomnography, as advocated by Dr. Matthias Bontart of Germany?
Yes. I like to do sleep studies early on in ALS. Afterwards, there's other ways we can answer those questions. The sleep study is best done with that transcutaneous CO2 monitor. So there's a couple of ways to get into assisted ventilation through a sleep study. One is that the PCO2 drifts above 50 while you're sleeping at night. And that happens even when it's normal in the day. And the other is that some people with ALS they bring into the disease that they acquire sleep apnea. And I think if you have if you have early ALS, you don't qualify otherwise, but you have sleep apnea, I encourage people to go use CPAP, the treatment for sleep apnea at least. It's a similar machine, it's the same mask, you get familiar with the whole thing, you get better sleep during this time in your life, and it's an easier transition to the higher level support, bi-level support or ventilators. So yes, I like sleep studies very early in the progression of ALS.
Okay. Yeah, another question about proactive measures to avoid breathing devices. We've covered that. Fancy ways to get around the breathing device. Let's see, Michael is asking, do you feel confident that the newer pulmonologists at UPenn ALS are as competent as you? We have not seen a pulmonologist at Penn for the 2 years we've been going. Forced lung capacity was measured at 80% last week.
Yeah. Right now, our team is me, two younger physicians, a nurse practitioner. You met our respiratory therapist. We have a social worker. We have an RN, an administrative person, and then consultants that we reach out to and very close relationship with our neurology practice. The two younger guys frighten me because they're so smart and they're so good. I don't want them to be outstripping me. So I have to study extra hard to keep up with two absolutely spectacular colleagues. I'll be very frank, our neurologists are coming around to the idea of earlier referrals, but still not as early in the disease as we would like. And I have to say, if they sent us everybody from day one, we would be pretty crushed. So that's the best answer I can give. If you know anything about Philadelphia, my two colleagues are incredible.
Okay, Philip says a person with 80% or less than 80% FVC can have significant respiratory dissatisfaction, in quotes. Should ALS diagnosis alone be the criterion?
Yeah, maybe someday, because in the grand scheme of things, these machines aren't that expensive, and everybody with ALS is going to need the machine. So what we're talking about is whether the insurer has to deal with several weeks, several months, maybe a year, slow-going disease of additional cost earlier on. So in the best of all worlds, I say you have ALS and you want a machine, you should be able to get it. Yeah. You're going to need it soon enough.
And I think one of the issues is, going back to your previous remark about machine, neurologists will refer people to pulmonary sooner, is beyond the many other reasons. I think part of it's out of fear, not from the neurologists, but the individuals, the patients. What? And people are in such unique circumstances. They're traumatized by the diagnosis. And at what point can we introduce them to all the possibilities? Because it's all about possibilities. So in essence, it's all about the art of language, and it's getting a little bit better. How much can people take in to look into their future? So that's the dance. And yet it makes so much sense for people to be aware, John, of, what you and others offer. And yet, when can they receive that information without being more traumatized? So,
as Pat said, I've asked Ron advice on how I should react and respond when people are not bought into the idea of leaning in, learning what's coming. The opposite side of that is cutting off a conversation, saying one day at a time, Doc, one day at a time. And everybody steers their own way through the disease and have to lay back and understand individuals. But I just fear that one day at a time, you land in an ICU on a ventilator unconscious, and your daughter is deciding whether you get a trach or not. So I've asked Ron, and he's a master at how to continue a good relationship with somebody as they're struggling with accepting the enormity of the disease and the things that maybe they're supposed to do about it.
thank you, John. James?
Melanie's wondering, does one have to go to your center in person once and then continue via telemed, or can the whole thing start via telemed?
Yeah. You have to come and see us. And for the most, pretty much, we can't do telemedicine outside of Pennsylvania. We were doing it for a while during COVID. All kinds of rules were abated. But we don't have licenses from Massachusetts to Virginia. And telemedicine requires a license in the state where you're sitting. So a couple of people have driven across the border and they're sitting in the car just across the border, so we could have that. So
Wow.
yeah, the short answer is we need to see you in person and have limited capacity to work out of state.
Can you, in
I
that,
do live near the Pennsylvania border.
and in that scenario, John, can you consult with their physicians?
Uh, yeah, I've done a fair amount of just helping people out.
Okay.
And I kind of reached my capacity.
Yeah.
I wondered if I should charge for it. I don't know. Off the cuff, non-physician patient guidance is an area that I'm struggling with a little bit, to be very sure, because
Yeah.
this could be a full-time thing for me.
Sure. Okay, thank you. James?
Okay, there are a couple more questions related to what you talked about earlier about strengthening your breathing muscles. An EMST device. Are you familiar with that?
Just spell it out, please.
EMST
Yeah.
device?
What does it spell? What does it spell?
I don't know.
Yeah, I don't know what the abbreviations are, but in general, you can't strengthen ALS respiratory muscles by exercise. And don't think. Remember, the problem isn't the muscle; it's the nerves. So the exercise doesn't have an influence on the declining transmission of a signal to so if very early on people hold their exercise back way hard out of fear of the disease, they become deconditioned, and you might be able to overcome that. But for the most part, I'm skeptical that breathing exercises or walking exercises or lifting weights is a major benefit to preserving muscle strength in ALS. It's a debatable and much discussed topic.
Okay. Jeff is asking about a cough assist. He's wondering if it's beneficial for a dry cough in addition to having mucus in the lungs.
Technically, no. But if you're having a disturbing dry cough, it might be worth getting tested for this and consider using it. We like to start it before people really need it, and they use it once a day or twice a day to be familiar with how it works. And then each time they use it, they're testing to see if there's mucus in their airways that they weren't aware of otherwise. So sometimes people have a dry cough if they don't have enough strength to move the mucus. So if they're weak enough, we might start them on it. And lo and behold, once we get the machine adjusted just right, that dry cough becomes a loose cough, indicating that they have a bronchitis and may already be aspirating.
Okay, great. Well, it looks like we reached the end of the chat questions. Thank you for staying longer. Eileen did find out what EMST stands for: expiratory muscle strength training.
Okay, yeah.
So same kind of thing, right?
Same answer, yeah.
Yeah, okay. Good. Well, thank you so much, Dr. Hansen-Flaschen, for staying late, and everybody for hanging in there with us with such a wonderful range of interesting and obviously heartfelt questions. Beautiful presentation, sir, and thank you for joining us today.
Thanks everybody for your attention, and maybe some of you can help advance the respiratory care of ALS in some way that works for you.